Welcome, everybody, to this educational program that's put together by Tactile Medical. With me today, I have a couple of newbies for the Tactile webinars, a couple of interventional radiologists, good friends, Kush Desai and Ron Winokur, which are going to give us a different perspective in comprehensive management of patients with leg swelling and underlying venous disease. As always, any questions or comments, please include it down in the Q&A icon. And this is intended to be very interactive, so please ask any questions so we can make this pretty interesting conversation. So go ahead, Kush, I think you're starting up.
Hi, everyone. Good to be with all of you. My name is Kush Desai. I'm an interventional radiologist at Northwestern in Chicago. It's always good to be with my friends Tony and Ron and my friends at Tactile. And I want to thank Tactile for supporting this program. And, you know, I'm primarily a deep venous practitioner, a deep venous reconstruction type of practitioner, complex filter retrieval. And as I've progressed through my career, I've sort of realized that I need to ask the question, are we really fully treating our patients' leg swelling? Is there more we can do? Can we optimize them even more? These are my disclosures. The first poll question: in patients with extensive, long-standing cable or iliofemoral venous obstruction, my day-to-day work, lower extremity swelling always improves after deep venous recanalization. True or false? Always is sort of a trick question in medicine. Nothing is always.
Yeah, make it a little bit too easy there.
Yeah, mostly improves. How about that? Wow, we have quite the learned group here. So,
leading question, Kush.
A bit of a leading question, but you know, this is the idea that we can't always fix all their swelling just with doing a procedure. There are other things we need to do. It's a lifelong thing that we need to think about and maintain and manage. So a case for discussion to kind of introduce this concept: 62-year-old female, history of a motor vehicle accident in the 1980s with significant polytrauma. While she was hospitalized, she was diagnosed with DVT and PE, and she was told an IVC filter was placed. Shortly after discharge, she developed severe left lower extremity and, to a lesser extent, right lower extremity edema. When she presented to me, she has significant pain that primarily occurs in her left leg with extended standing or walking. She's a medical device rep, so she's on her feet and is really out and about quite a bit. And she's underwent superficial ablation and treatment at a local vein center approximately 6 months prior to seeing me. On exam, she has 3+ edema involving the entire left leg, varicosities above and below the knee. She has mild to moderate left dermatosclerosis. She's never had a wound and doesn't have one currently. Really doesn't have focal erythema, cellulitis, anything like that, but she does have LDS, eczema, some fibrosis. She does have 1 to 2+ edema in the right leg, but really the left leg is a dominant issue. And she has a positive stemmer sign on the left.
So Ron, in somebody like this who presents with advanced CVI, you know, what are your thoughts about them jumping on treating the superficial veins?
It's a great question, Tony. I don't know.
Especially with a history of DVT and a filter and everything.
I would want to look at the deep venous system, and I would want to know what the status is of the deep venous system before I go after superficial venous insufficiency. That being said, there's plenty of people who treat the superficial side even when there's deep vein obstruction. I find it, you know, sometimes it's a hard decision to make, and everybody has their own area of expertise and specialty in choosing which goes first. If I know that they have iliac obstruction, I tend to go for the obstruction before the superficial side, like you're suggesting. And I think you probably agree. And it'd be nice with that history to tip somebody off to say, well, maybe we should look to see if the deep system's open before starting the ablation.
At a minimum, I agree, you know, looking at the deep system. And the second question is, what is their, you know, if they had an ulcer, I would say, okay, maybe treat the superficial first to see if the minimal thing can help get them healed. But because of the significant pain, treating the saphenous vein is not going to get rid of the pain.
Agree.
So,
yeah, her complaints are swelling and venous claudication. right? And we know with this degree of swelling, saphenous ablation isn't going to fix it, right? And with her venous claudication, saphenous ablation is not going to fix it. Surely the cosmetics might improve, and if she had a wound, absolutely. Axial ablation may be enough. So this is what her leg looks like. And, she has progressing towards an elephantiasis type of leg. The DUS, chronic post-thrombotic changes of the left pop through the left common femoral veins. On the right, everything's normal and compressible, phasic. We do CT to look for proximal imaging, for axial imaging of the abdomen and pelvis. And I'll slow it down, but that's no filter. That's an Adams-DeWeese clip. And she was...
So what's that, just in case our audience doesn't know what that is?
This is a clip that was placed operatively. When was it, Tony? Late 80s, probably. Mm-hmm. Before the Moba-Newton filter, and then subsequently the Greenfield filter. And this was a filter. This was not a filter, an externally placed IVC clip to ligate or plicate the inferior vena cava so no clot could come up. So it's like a filter functionally, but it's on the outside. But there are problems with it, as you'll see. So she has this Adams-DeWeese clip. And as you go down, you can see that she has post-thrombotic changes in her left iliac vein.
Yep.
So you just want to explain what the post-thrombotic changes are that you're seeing as far as kind of like calcification, small caliber, that kind of stuff?
Yeah, let me pause it real quick here. We'll just kind of scrub it through. So as we're coming down, you can see that the vein is pretty small here. And as we go down further, you'll see this calcium right there. And that's not normal. The vein should be bigger than the artery. And in this case, you can tell clearly it's not. It's
just comparing it with the other side too.
And you compare it with the other side. That's what the DeWeese clip looks like on a sagittal image. You can see how it's really kind of just puckering it closed. So next poll question, what would you do? Treat this patient with compression. She's been using that. Just compression, continue compression. Would you do deep venous recanalization and further workup and treatment of her swelling? Or really nothing is going to alter the course of her disease?
So Tony, I feel like this is an interesting question. It's kind of the idea, is a DeWeese clip something that you can recanalize safely endovascularly? Do you need a surgical approach to remove that? Is it something that should be attempted?
I mean, I have never attempted it. I haven't seen a patient with a DeWeese clip, but it's documented in the literature. Several cases of recanalizing it. You have the little holes in between the clip, so if you can get a wire through that and just pop it open with a balloon.
I'll show you what I did. All right.
I'm surprised that the wire will find its way through those holes.
Yeah. Well, it's Kush Desai. He can get through something that doesn't exist. Right?
Tony, don't talk me up too much. So do we expect the swelling to improve purely based on our exam and based on a recanalization? Do we think that the swelling is going to get better entirely? And do we expect venous claudication symptoms to improve, or do we expect both to improve or resolve? And that's the question. And we'll find out. I know what I expect going into this. And I try and counsel my patients to tell them that we expect this component to improve. And I don't want to give it away, but I don't necessarily expect this to improve much. But it was an interesting course. So here's the venogram, and you can tell there's post-thrombotic changes. Not terribly difficult to cross this, but clearly there are cross-pelvic collaterals. There's compensatory dilation of the right iliac vein, as you see here.
Now, any role of ignoring the clip and just fixing the left iliac?
Yeah, no, absolutely. And I'll tell you exactly what I did. I ignored the clip at first.
Oh.
We were able to get a wire through it very easily. You can see where the teeth of the clip are biting down on the vena cava.
Uh-huh.
Place the stent, and I just wanted to show you exactly where all the lesions were. Post dilated it, and this is what it looks like at the end. Left lower extremity swelling significantly improved. Gone. She was ecstatic for 1 week. And then it came back. Exactly the same. 1 week.
So how do you explain that?
We're going to talk about something called the Starling principle in a couple minutes.
No, but how, it went away completely and then it returned?
Well, almost completely, right? I didn't see her in that week.
Okay.
She came for 1 week follow-up, but she's like, my legs look so much better. I suspect it didn't improve entirely. Hang on 1 second. My resident is calling me.
I have a feeling, Tony, her symptoms got better. And so she felt like her leg was better, but the swelling really didn't improve.
Yeah.
Right. Exactly. So I think the swelling may have redistributed a little bit, but that's about it. Mild improvement in the venous claudication symptoms up front, but she still had them. It was still there. So what's next?
Kush, do you need to take care of the patient?
No, go ahead.
So what next? Well, I guess address the IVC.
Is exactly what we did. So I put a balloon between each of the teeth and started popping the clip open. It's actually not something you can easily see with IVUS, because once the IVUS gets to that level, it looks like a black hole. You really don't see anything, actually. I tried to get great IVUS pictures, and then I used a big balloon. And you can't really even see the clip here, right? It's not radiodense.
Yeah.
Then I put a G-Interco Z stent inside of it to really hold it open. Wide interstice stent. Just checked my iliac vein because I'm there. And everything looks good. Sort of left lower extremity edema again improved significantly. She was ecstatic. And then back to baseline. But now all of her claudication symptoms are gone. And this is a woman that is not, I don't think any of this is the placebo effect. She didn't want extra stuff done. And so we just kind of went through it incrementally. Swelling's back, it's bad, but the claudication symptoms are gone, and that's her leg. Here's a
curiosity. Did her stemmers ever go away? Like, did she have a positive stemmers the whole time?
She did. Her swelling never completely went away. You can tell, but you can even tell back. I'll go back to the picture. That's a pretty good looking left leg.
It is.
Compared to what it was.
I mean, she definitely still has a stemmer.
Yeah. She's the malleoli are featureless, and she's got that, hump, but that's worse.
And this is something, how long has she had now this swelling?
Years. She was in a car accident like almost 30 years ago.
Mm-hmm.
So CT shows that the clip is now popped open, right? The vena cava is open. The iliac stent is open. And she's kind of reached her new sort of baseline. So the next poll question, why didn't the swelling get better? And what do we need to do next? Just compression therapy, or do we need to start thinking about focusing on what is probably phlebolymphedema?
And Kush, at this point, does she have any superficial disease left?
Not really. You could see her legs in. I mean, she has really mild LDS. The varicosities are gone, mostly gone.
Yeah, I mean, the majority of people obviously agree with managing her underlying phlebolymphedema. The question is to you, did you do any therapy prior? Did you try as far as managing? Because she obviously has a component of lymphedema, whether it's, isolated lymphedema or phlebolymphedema. Because she did have a motor vehicle accident. I saw a huge scar on her leg, so it could be post-traumatic.
Right.
Or a combination of that plus venous.
Right. So she was on compression and she was getting MLD. She hadn't yet gotten a pump.
Okay.
She has one now, though. So we're going to talk a little bit about the relationship of veins and lymphatics and chronic venous disease. This is
so before you do that, Ron, how often do you see this where you do treat the venous problem that the patient gets sent to you for, and they're still not really getting much better or mild improvement?
It's probably somewhere around 20 to 30% of the patients that we treat, and where they don't get an immediate response, the swelling persists. And they usually have other changes, other signs, just like Kush was saying. They're going to have a positive stemmers from the beginning. You're going to get maybe worse induration and skin thickening than you typically would see in these patients. I think some of those more severe patients that have had long-lasting obstructions is when I feel like I see it occur more often, that they don't get this improvement.
Yeah, if you look at the literature, it varies anywhere from, and again, depends, any residual, right? Swelling, even if they have mild residual swelling, is anywhere from actually 40 to 60%, with the more advanced deep venous problems causing more injury to the lymphatic system. And Kush, why don't you tell us about that?
Yeah. So, the lymphatic system is relative to the other vascular beds is the hinterlands, where we're really just developing a much more robust and sophisticated understanding of it. And even venous disease compared to arterial disease, our understanding is well behind. What is lymph? It's about 96% water and 4% solids, largely proteins, lipids, antibodies, enzymes, lymphocytes. It serves as one of the main immune pathways by which antigens are presented to leukocytes that mount our immune response. And the Starling principle talks about tissue fluid hemostasis, really filtration at the capillary level. But there are a couple important differences between lymphatics and then arteries and veins. Arteries and veins have a pump behind them. The arteries have the heart, the veins have the calf pump. Specifically, the lower extremity veins have the calf pump. There is no pump behind lymphatics. The other thing is that arteries and veins are filled. They're primed. They're filled with blood. It's entirely normal for lymphatics not to have anything. And in fact, for them to have normally a negative pressure. In normal asymptomatic people, their intralymphatic pressure may be negative 6 millimeter mercury. So lymphatics can be these collapsed channels, but then when they get filled is when the disease starts to manifest. So, Starling, he was working on a much simpler system, and we've had to revise our understanding of it. And it really comes down to the glycocalyx. And you have to take interstitial fluids into account. There's no steady state venous reabsorption, but rather dwindling function, as you see here. And we'll talk about how that plays in specifically with venous disease. Lymphatics, not the veins, are primarily responsible for maintaining tissue fluid balance. You can have venous obstruction, and if they're really, really well collateralized, the blood continues to return and doesn't go into the lymphatics. So Ron and I see, and Tony sees patients, we see patients that have long-standing venous obstructions, really significant venous obstructions, but if they're well collateralized and there's a way for the blood to get back, sure, they're not normal from a venous perspective, but they don't have lymphedema because the fluid is not backing up into the lymphatics. It's when they're not well compensated is when we have real issues, and then the lymphatic system becomes overwhelmed. And therefore, all chronic edema indicates an inadequacy or failure of lymph drainage, at least to some extent, if not to a dominant extent. What is normal system? When the interstitial pressure exceeds luminal pressure, fluid is pushed into the lymphatics, as you see here, and the lymphatics try and kind of keep up with it. When you have lymphedema, you have lymphatic dysfunction. As you see in this picture here, you're not seeing any of the telltale signs of venous disease. You're not seeing varicosities, and you're not seeing any of those things. You're just seeing edema primarily, and then obviously the nails don't look so hot here in this picture. And then the interstitial fluid comes out, and lymphatic dysfunction happens when it can't keep up. When you have chronic venous disease, such as early venous disease, you have venous hypertension, and the interstitial fluid tries to make its way, and lymphatic flow can compensate up to 10x. But once it reaches that most significant state, particularly in post-thrombotics, where you not only have superficial dysfunction, but deep dysfunction, is when you really are overburdening the lymphatics. In the C3 patient, venous hypertension, as you see in this ultrasound, there's kind of this hypoechoic appearance to the superficial subcutaneous soft tissues. You have interstitial fluid buildup, and when it becomes decompensated, the high lymph overload overwhelms the lymphatic system. So how does CVI cause lymphedema? In the normal system, interstitial pressure exceeds luminal pressure, fluids push in the lymphatics. When the system is overused, there's increased venous filtration, 10x, as we talked about, and it's compensated. But it gets to a point that it can no longer keep up, and you have lymphatic insufficiency because it's decompensated. And when it's full-on damage of the lymphatics and continuous overuse and high luminal pressure, much like the first patient, 30 years of obstruction, not only from an Adams-DeWeese clip, but also unilateral iliac obstruction, you have phlebolymphedema, which is only on her left side. Both legs are seeing the cable obstruction. The left leg is seeing the cable obstruction and the iliac obstruction, and the lymphatics in the left leg have been overwhelmed for a very long time focally. PTS patients, why are they specifically at higher risk? You have deep vein thrombosis, which results in reflux from damage of the valves, and obstruction due to non-compliance of the venous wall. Remember, veins are bags, not conductance vessels or capacitance vessels. They become inflamed. They no longer have a good compliance, and they become firm and rigid, and they can't keep up when arterial inflow to the leg increases, such as when people are standing and walking. That leads to higher venous hypertension, ambulatory venous hypertension. You have progression of disease that's faster. And in these patients, we're seeing more and more venous edema is actually phlebolymphedema after the venous obstruction is treated, if it can be. Lymphedema from impaired lymph drainage with normal lymph flow is generally irreversible. Early stage venous edema, if you catch them early, say a DVT, for example, and you clean out the DVT if it makes sense, an iliofemoral DVT, it's potentially reversible. The high lymph flow is at that 10x, but it's not for an extended period of time, and then it redistributes back into the vein. And when you have phlebolymphedema, as you saw in the first patient, you have lymphatic failure resulting from sustained increased venous fluid filtration, and that becomes equivalent to lymphedema, where the lymphatics themselves are exhausted and eventually damaged, and this is a generally irreversible process that needs to be chronically managed. Very busy slide. Tony really should be the one talking about this because he developed it. But this has been enormously helpful for me. It's a diagnostic pathway on how to think of a patient with chronic peripheral edema. And this is so much of this is diagnosis of exclusion. Think about what things you can help and fix. And if you go through this first systemic cause, then you move on. Remember, if somebody has bilateral edema, you have to think about systemic causes. Unilateral edema does not usually have a systemic cause, but bilateral edema does, and you need to rule out all those other medical causes to make sure that there isn't something that's potentially reversible from those conditions. And if it's a no there, then you move up to the top and you do your history and physical, you do your diagnostic imaging, you look for all sorts of things, the obstructions, et cetera. And then you figure out, and if there's no obstruction, it is true lymphedema. And often the patient will tell you, well, I've never had a DVT, and your duplex is completely normal, then it's lymphedema. But if they've had these other things, if they've had an impact or some sort of disease process of their deep veins, then you need to think about, what can I improve? And in this patient, actually, for the sake of this webinar, I told her up front that your edema is probably not going to improve much. I knew that it wasn't going to, but what surprised me was that it momentarily improved and then returned. It's almost as if it was trying to re-equilibrate, but the lymphatics are so damaged that it just settles back to where it was beforehand.
So Kush, if we talked about failure of therapy to get rid of edema in about 50% of patients or so, and you thought it wasn't going to work. So why not just treat him with MLD, compression, and a pump and leave him alone?
Because So it's multifactorial. MLD in the pump is going to help with the swelling. It's not going to help with venous claudication. So we can make this patient's quality of life better from treating the venous claudication. You need to do both. I think that's the important message here.
And like you said, expectation of the patient as far as what to expect after treatment is important. Right. It's kind of almost, I think about this in general, like venous ulcer patient, right? They go to the wound clinic, they get their wound care, they get their hyperbaric, months and months and months go by, and their underlying problem is not addressed.
That's right.
So think about this kind of similar. If it's venous cause and you don't treat the venous cause, then you're never going to get them better. Or if it's truly a lymphatic cause and you just put a stent in and then it'll go better and you don't address their lymphatic problem, they're still not going to get better.
That's right.
So you have to manage these patients globally when you address it, just like a venous ulcer patient.
I mean, I've seen patients with a compression, non-thrombotic, by imaging, and you look at their leg, and this is lymphedema. And I'm not going to put a stent. If they have venous claudication, that's one thing. But if the complaint is swelling, that's not going to get better. If they have a big sausage-looking leg, it's not going to get better with a stent. Stents don't fix that kind of swelling. Stents fix swelling that gets worse with activity that has atypical features for lymphedema. And when a non-thrombotic comes in and they have swelling, they almost always have venous claudication associated with it. And those are the people that are actually going to get better. And that's the important message with doing an intervention in those kind of patients.
And I just want to make it clear for everybody. I mean, we're putting down stents here, but there is a group of patients that do improve their swelling when you treat them.
There is.
But the key thing here is that, it's probably like a flip of a coin. And it mostly depends on how good of a history taker you are.
Yep.
Like Kush said, if it's an isolated nivel lesion and the leg looks like lymphedema, that's not the patient that is going to improve. Versus a venous type of swelling, may have post-thrombotic, maybe superficial on top of it. And the key here is making sure the patient understands, if you're looking really for relief of symptoms from your swelling, I tell them 50, 60% chances I can make you better.
Right. So another brief case to wrap up, to illustrate and kind of drive this point home. This is a different patient, 63-year-old, history of bilateral deep vein thrombosis 10 months prior to presentation. She had bilateral lower extremity edema initially that improved somewhat. She has edema and pain in both legs progressing throughout the day with activity, and her past medical history is pertinent for endometrial cancer. She was previously on apixaban, was felt to have failed at that time, was transitioned to enoxaparin. That is a deeper conversation on whether she should have been on a DOAC in the first place as a cancer patient. Probably not. Post-thrombotic changes in both common femoral, and popliteal veins. Her profundus patent bilaterally. And we got the CT. And as you can see here, it's going a little bit fast. That's not a normal looking vena cava. It's kind of lobulated. It's smaller than the aorta there, which unless they're profoundly dehydrated or hypovolemic, it shouldn't look like that. And then you can see that the iliac veins look abnormal. They're very small, just like our last patient. But this patient has bilateral iliac vein disease. So there's a reason why they have their bilateral swelling and bilateral venous claudication. She has involvement of both common femoral veins, so we have to access below the level of the disease. I do these patients under general anesthesia in a prone position, and you can see what the initial venogram looks like on both sides. It's a typical post-thrombotic appearance, as you see, probably worse on the left than on the right, remembering that they're prone here. Sorry. Seem to be frozen. Oh, it was very frozen. Okay, so we do the IVUS, and you see there's post-thrombotic disease right here, pretty typical on IVUS. My computer seems to not be happy with me at the moment. We recanalize it. I won't show the IVUS but the stents look great. She's transitioned back to apixaban she really just didn't want to be on any sort of injectable blood thinners. Her swelling did improve. It did.
Thank you, Kush. We have actually, there's a question from one of the audience. Any other one of you. So you have an 18-year-old girl, a female, presents with unilateral leg edema, which started at the age of 15 after an ankle sprain and international flight to Spain. Swelling did not resolve. She was assumed to have lymphedema precox and has been treated for the last 2 years with MLD and compression. She continues to have significant swelling, only minimal improvement in her edema with about 7% reduction after 5 sessions. Her leg immediately refills within 24 hours after her dressing comes off. Do you think there's a venous cause here? Potentially.
Has any workup or imaging been done to see if there's reflux in that leg or obstruction in that leg?
Nothing in here, but given the story, and again, if the timing is correct, unilateral swelling at the age of 15 after a ankle sprain, not really a fracture, but depends on how bad. Was she immobilized? Potentially, because she'd have had a DVT that went unrecognized.
Yeah, it could have been silent.
Yeah, I would have definitely worked her up. MRI negative for DVT.
MRI.
Yeah, that's not really the best test for working up a DVT. I would definitely get a venous duplex in this patient.
Venous duplex, and then if there's suggestion of anything up, if you're able to get a great iliac duplex, if not, I would do CT personally over MRI. MRI requires a lot of local expertise.
I agree with Kush.
Yeah, I mean if she's had pretty extensive lymphedema therapy and really not much improvement, I would at least consider looking for a venous cause.
And I think, was it a left leg? Is that?
No, it's the right side.
Right leg.
The right leg. All right. I mean, there can be a non-thrombotic compression. It's just so much less common in a young patient on the right, I feel like.
Correct.
Very uncommon, yeah.
And the other thing is, if especially if she happened to be on oral contraceptives, with this injury, potentially, she could have had a DVT.
Right. That's kind of what suggests that they should look at that. Yeah.
Yeah. All right. There's no other questions. Ron, you want to share your screen? Any?
Sure.
Very nice, Kush. Thanks. And really, the purpose of these couple of talks that were put together is to show what I mentioned earlier. Think always the patient globally, whether you're a therapist and you only do, if you're a therapist and only you're treating the lymphedema component, you don't really think about the venous. And if you're a vein specialist, you're only thinking about venous and you're not addressing the lymphedema. So the whole purpose of this presentations is really to say, these two systems interconnect and are dependent on each other. And sometimes treating you almost never can only treat one side. especially when you're on the advanced stages. Go ahead, Ron.
Tony, you just took my whole talk and my introduction to it.
You did? I'm sorry.
That was right what I was about to say. No, it's perfect. The goal of kind of the next few slides and what I'm going to go through is exactly what Tony was saying, the comprehensive idea that venous disease and lymphedema are going to be interrelated. And you have to think in both directions. And so if you have untreated lymphedema or somebody who's not resolving with lymphedema treatment, think about venous obstruction, and same as Tony said, the other way around. Here are my disclosures. And the goals of what I'm going to talk about are...
We went from the dark slide
to the light
slide.
So the goals of this are understand the interaction of venous disease and lower extremity edema and lymphedema, understand minimally invasive strategies for patients with venous disease. So I'm going to show a couple cases and also going to show obstruction case, but combined with superficial disease. So how does deep and superficial disease work together? So here's that first case. This is a 65-year-old patient, and he had a history of a stabbing to his right groin 15 to 20 years prior to presenting to see me. And during that stabbing, he had severe bleeding. He had a cut down in his right groin. And when they did the cut down, he was told that they tied off some of the vessels in his groin and they had to control the bleeding. And ever since then, he has severe swelling in his right leg. And it was getting worse. And so he eventually came to see me after having 3 to 4 months of worsening symptoms in that right leg. And so when I saw him, here's his imaging workup. I like to do, much like Tony, I do ultrasounds in the office of the iliac and iliac system and IVC. So we look at his iliac system, and surprisingly for this history, you would think with that traumatic history with tying off a vessel in the groin, that this person would have iliac obstruction. I was expecting to find complete extensive iliocaval occlusion and post-thrombotic syndrome. And I was surprised that he had really normal patency of his iliac veins. So his right common iliac and external iliac, you can see on this first image, this is the common iliac vein here, the artery on top. We're getting down to the turn where the internal's coming in and the external iliac would be out this way. This is now looking more peripherally. Here's the hip right here. Here's the common femoral going into the external iliac vein with downward flow. And I'm just showing you color images with some spectral tracings with respiratory variation, but clearly seeing patent normal vasculature. Then we went to the common femoral vein, and here I'm just showing some compression pictures, and it looks like the vein is pretty much compressible. Here's the artery in both of these images. It's at the saphenofemoral junction. So here's the great saphenous vein coming into the common femoral here. It compresses, maybe it doesn't compress fully. Maybe there's a little bit of a thickened wall. So it looks a little bit out of the ordinary there. We go down into the leg and you can see here's some selective images of the femoral vein as well. Here's artery with flow, femoral vein with no flow that's very small and post-thrombotic. Same as we keep working our way down the leg. Artery with flow, femoral vein with in the mid-thigh with absent flow and small caliber. And then as we get into the peripheral thigh, same thing, absent flow, small caliber, post-thrombotic femoral vein. So in general, the imaging shows a patent iliocaval venous system without any areas of compression, no post-thrombotic changes, no acute thrombosis. And he has a severe post-thrombotic change in the right femoral vein with absence of flow. And we did a superficial study at this time, and patient has dilation and reflux of the right great saphenous vein. It's 9.4 millimeters with 1.5 seconds of reflux. So we have a combination here, deep and superficial disease, but it's predominantly femoral popliteal deep disease and superficial disease. So I don't know, before I already showed my slide of kind of how I went to progress through this, but we can kind of stop and discuss. Tony, you asked me earlier, deep or superficial first, how do you approach it? Here's kind of an example of that situation.
Yeah, this is not as straightforward, obviously, but the question is how much is each contributing to the patient's symptoms.
Yeah.
And unfortunately, we really don't have a way of measuring that. And we can say how much reflux there is, maybe duration-wise, or how big the vein is in the superficial system. And similarly in the deep, if there's stenosis, if it's in the iliac percent area reduction, but no way of hemodynamically being able to tell how much each system is contributing.
Yeah. And what was shocking to me and why I chose to go for the deep system first was 1.3 seconds, 1.5 seconds of reflux in a 9 millimeter vein in somebody with a massively swollen leg. It doesn't seem like enough volume of reflux.
Correct.
To explain what we're seeing and the degree of swelling that we were seeing.
And that's and again, if there's any ultrasound techs on this, it's important to make sure you're doing a good reflux study. Number one, the patient has to be standing. Number two, you need to, especially if they have a big leg, you may need help to get good augmentation. And if you squeeze the leg just a little bit, you're not going to get much reflux back if you don't propel much blood up. So, and I've seen that where, they tell me there's no reflux and I go in and I squeeze with both hands and the reflux keeps going, across the screen. But it's important if you do find there is no minimal reflux and the vein is big, 9 millimeters, you may be tempted to fix it. But quite rarely, like 5% of the time, that saphenous vein is a bypass and not, and is helping drain the leg. So you got to be careful in those patients. You're not ablating somebody that may get worse.
Exactly. So I tried to go after this deep vein obstruction. So here you can see images of the right groin. We accessed popliteal, had him supine for this, but accessed.
And when you shot from the popliteal, there was no popliteal profunda collateral?
There was no popliteal to profunda collateral.
So
he actually had very few collaterals, as you can see, for somebody with
that's odd,
right?
Yes. And I think that's why he's profoundly symptomatic.
And that's why the saphenous vein is 9 millimeters.
It's his bypass.
Yeah.
I mean, we say it's never a bypass except when you have no deep femoral axial transformation.
Yeah. And so that's rare. That's less than 5% of the time.
Yeah, that's rare.
This case is extremely rare. So was able to get through that chronic post-thrombotic femoral vein up to the common femoral. And you can see the arrow pointing to this occlusion. It's a linear line. They literally tied off his common femoral vein. And we weren't able to get through from below. So we ended up accessing from above. And you can see it's just going into the saphenous. This is the top of the GSV right here. And all the flow is going straight into the great saphenous vein. And we have an absence of the common femoral vein there as well. So I ended up bringing him back for reconstruction with a radiofrequency wire. So I repeated that access from below, got right up to the area of occlusion. And then here I put a snare in from above as a target and used an RF wire to cauterize a track and get across that obstruction. You can see how tight that track is. So we were able to balloon that open and we put a stent in the common femoral vein there. And we were able to get that open, get really great inline flow in the common femoral venous.
So was the vein just ligated or
I think it was just ligated.
So it wasn't.
They may have taken an extravascular track. They may have, but in the end, it was mostly just ligated. So this is his follow-up. So pre-procedure, his leg was pretty swollen. 3 months post, still pretty swollen. 6 months post, doesn't really look much better. Maybe there's a little less swelling in his foot, but hasn't really changed. And his symptoms have gotten better. His leg doesn't feel necessarily as heavy, but it's huge. So it still bothers him pretty dramatically, and his swelling is persisting.
Yeah, if anything, it looks worse in the middle.
I kind of agree. So we started a little bit of lymphedema therapy at 3 months that got him from 3 to 6. but he still didn't totally get better.
And you can see, go back. This is not your typical, doesn't really have much, a little bit foot involvement, but nothing, typical for lymphedema. The classic lymphedema findings in the foot.
There's a question. Would you have closed that saphenous given that there was no profunda transformation?
I would not.
You wouldn't do
Especially
it
if that 1
front.
second reflex was true.
Tony, you wouldn't do it up front. You wouldn't do it first. Would you do it ever?
If that's really 1 second reflex only, I don't think so.
Yeah, without a profunda that's draining the leg, I don't know. Again, it's a rare thing, right? But you never saw.
Once he's draining, right? So now he's open.
Remind me.
All right, Ron. Show us the picture where you treated the saphenous and his leg got better.
Well, let's ask the poll question then. So I guess the poll question is what do you expect to be the cause of persistent swelling in this person with known reflux, deep vein obstruction, who's now been opened up on the deep venous side? What are you favoring as the next cause? Is this stent occlusion? Is it superficial vein insufficiency? Is it just lymphedema? And we're not going to fix it with any vein intervention.
I'll tell you, if that saphenous vein is causing that much edema up into the thigh, I'd be impressed.
You'd eat your hat.
Yeah. And then there's no way it's only 1 second of reflex.
Agree. So I'll keep moving along. So I keep following this patient and we keep looking. Stents are wide open every time he comes back. And he calls my office, I don't know, once every couple of weeks and speaks to my nurse practitioner and she gives him lots of reassurance and we keep giving him guidance. His stent's wide open every time he comes back, but his GSV is huge. Now maybe he has 2 seconds of reflux and you can see the augmentation here. Tony, you tell me if you think I squeezed hard enough on his leg.
Yeah.
Pretty good augmentation, I think.
And the edema goes up in the thigh.
Yeah. So I ended up, I didn't have any real good options for him. He was getting lymphedema therapy. He wasn't responding. We were trying to get him a pump. We had fixed his obstruction. So we decided, let's see if we close this great saphenous vein, if it helps him along. So here's some images. Here's the great saphenous vein near the saphenofemoral junction. We decided to use Venous-Seal glue for him, even though his vein was fairly large, just because he couldn't tolerate compression stockings and he couldn't tolerate ambulation with thermal ablation. So we thought this would give him an opportunity to close the great saphenous vein. So here it is. Here's the Venous-Seal catheter within the central great saphenous vein, and then here's glue in that great saphenous vein. So we had closure of that vein. I guess we can come back to him a little later, or we can talk about it now, how he did. I mean, he continues to have swelling. He's continuing with a pump. And the last time I actually just saw him last week. And now that he finally got a pump at home and he's using it appropriately, his swelling is finally improving. And so I think a large component of this is lymphedema. And that lymphedema is from long-standing phlebolymphedema. He had venous obstruction that led to maybe some reflux and collateralization through the superficial system, but he totally overwhelmed his lymphatic system, and it just never recovered.
That's an interesting answer.
To my poll question?
Yeah.
Yeah. So yeah, what's the approximate incidence of chronic venous insufficiency in the lymphedema population? So it looks like a good number of people think it's fairly high, 70%. I guess here we are as venous specialists talking about venous obstruction and venous disease, and it's causing lymphedema. Let's kind of go forward into these slides because that's a bit higher than what it truly is. So if we look at some of the data, here's some data from Stephen Dean. Phlebolymphedema is the predominant cause of lower extremity lymphedema, but that number is not quite 70%. It's more in the 35% range, at least in this particular study. And then if we look at some other data from Raju, lymphatic dysfunction is common in patients with advanced venous disease, 20 to 30%, so similar to the paper by Stephen Dean. With advanced venous disease, we'll have associated lymphatic dysfunction. And we know that there's a large percentage of patients out in the United States, at least, who have advanced venous disease. So that means 30% of this 6 million are going to have some component of lymphedema that we're not addressing. And the problem, as Kush described really nicely, chronic venous disease, you get accumulation of interstitial lymphatic fluid, and then you get this dynamic insufficiency and mechanical insufficiency. You get overwhelming of the lymphatic system, and then the mechanics of the lymphatic system become obstructed, and it can't function to clear the lymphatic fluid. So if we look at this in a slightly different algorithm, here's kind of the downward spiral of lymphatic dysfunction. So start by overwhelming or overloading that damaged lymphatic system. Then you get a compromised immune response. You start to get skin infections, cellulitis, induration, redness, and eczema. Then you start to get a red inflammatory response that turns into lipodermatosclerosis and fibrosis. And then you start to get into recurrent infections and ulcerations, and you keep this cycle circling downward over and over again. So we know that venous recanalization can improve symptoms. Iliac vein stenting reduces pain and swelling, and at least swelling in this data from Neglin can be reduced from 36% to 18%. But like we were saying before, pain and symptoms are probably a bigger impact, and ulcer healing is a big impact of iliac venous stenting. But there can be some improvement in some percentage of patients who have swelling, but it's usually some form of combined with other symptomatology. In a meta-analysis of over 1,000 PTS patients, there was resolution in pain, swelling, and ulceration in 69, 63, and 70% of stented patients with infrequent complications. So these are pretty good numbers, seeing resolution of the common symptoms that we see with post-thrombotic syndrome and iliac vein obstruction. And swelling, not necessarily lymphedema, corresponds to that disease process.
So on the flip side of it, about 40% to 50% have persistent swelling even after intervention.
Yeah.
In both of these papers.
Exactly. And so we talked a lot about deep vein obstruction. I just want to briefly kind of go into the picture of axial reflux and superficial venous insufficiency, because venous hypertension due to reflux also can overwhelm the lymphatic system. And it can also lead to the same downward spiral of lymphatic dysfunction. And so increased venous capillary pressure increases ultrafiltrate reabsorption, and it increases that load on lymphatics. And there's a limit to the volume that the lymphatic system can tolerate. And so axial reflux, great saphenous vein, small saphenous vein insufficiency is important to include in the workup of these patients, especially the leg swelling patients. If we look at outcomes after endovenous ablation, here's 1,600 patients or 1,600 limbs that were treated with endovenous ablation, 528 limbs with at least C3 disease. And this is follow-up for a good number of days, 1,500 days. And they were surveyed for the degree of edema, use of compression, and satisfaction with their procedure. And here's the outcomes of that after endovenous ablation. And here are the questions that they asked. How much swelling were you having shortly after your procedure? 73% said none. So almost 30% of them are still having swelling shortly after the procedure. At the time of their questioning, how much are they having swelling? 59%, 60% don't have any swelling. That means 40%, again, after endovenous ablation have residual swelling in the leg, and there's probably some other component that's impacting that. And so clearly we're not treating the entire picture if we're only addressing the venous disease and not managing lymphedema that corresponds with that. Here's yet another paper. This is, again, Neglin, relief of pain and swelling And there's residual swelling in 70% of these patients who had chronic obstructive lesions that were treated. So here's one more case example. Here's a really interesting case that was referred to me from the outside, 88-year-old male. He had worsening swelling for 5 years. In his 80s, this came about. And he saw a vascular specialist in my area, in my community, and they weren't sure what to do with him. He had no response to diuretics. There was a cardiologist managing him, trying to see if they could manage this with diuretics. He had a hospitalization for ulceration and oozing from his lower extremities that required prolonged hospitalization at his age, wound care, and then going to a rehab facility. And he has no prior history of DVT. He has no prior history of filter placement. He has, nothing to suggest iliac obstruction, like the case that Kush was describing and like the cases we've been talking about. And so this vascular specialist at the outside evaluated him, and he happened to have superficial venous insufficiency. His great saphenous vein was refluxing. And, I don't know, Tony, 88-year-old man with swelling, if we looked at all the 88-year-olds in the world, we probably would find a lot of superficial venous insufficiency. I don't know how much of it's going to lead to that degree of swelling that we were seeing in that patient.
Yeah, no, I agree. And I wonder if the veins were even refluxing.
Well, yeah. So they ended up ablating his great saphenous veins to the mid-calf on both sides. I think they used Venous-Seal with his age, and they closed down to just below the knee. So he came to see me for a second opinion after all of that. And I did a reflux study. He did still have reflux in the standing position in the great saphenous below their closure in the calf. You can see my drawings there. His small saphenous was normal. There was no small saphenous reflux. He had no DVT. His femoral vein, his popliteal vein, his common femoral vein were normal. There was no deep vein insufficiency even when the standing position. Did an iliocaval ultrasound of him. His common iliac externals, common femorals, completely normal. No post-thrombotic change. No retrograde flow anywhere.
So you're looking at the venous here. When or do you ever look at the lymphatic system with ICG?
So I don't have accessibility to get good lymphatic imaging at my institution, but I think it's a great question to ask. It's a tough one to get, but are you able to do it where you are, Tony?
No, I'm just asking. One of the audience was asking the same question.
It's really difficult to get good lymphatic imaging. Very few places do it well. It's really resource and time intensive.
Yeah, I mean, there's some institutions. I mean, I was in a webinar yesterday with a vascular surgeon out UCSF, and they, if they have phlebolymphedema, they routinely do ICG imaging on those patients. But they have the setup. They have people interested in it. Not sure how much additional information if you're not planning on doing any lymphatic surgery on the patient, but.
So I think, this patient clearly has lymphedema. Is it primary lymphedema? And why did it develop? Is it infectious related? Was it a cellulitis that eventually led to lymphatic disruption, and primary lymphedema and all of the venous disease is just secondary to that, which I think is possible?
Most likely, yeah. I mean, because you could tell even from the legs, it doesn't look like venous cause of lymphedema for sure.
Yeah. So in summary, venous disease and lymphedema are obviously intimately related. And whenever we're thinking about venous disease, we need to think about the entire picture and look at both the deep system for deep obstruction as well as the superficial system. Both can overwhelm that lymphatic system and lead to chronic lymphedema.
And this is a great case to bring out this next point, which is, although we've talked about the venous system and lymphatic system really intertwined, if you do image every patient with lymphedema, you are going to find venous disease. And there you have to be careful you're not over-treating the venous disease if it's not really the cause, and their lymphedema is secondary to another thing. So you gotta really And really it's a combination of, physical exam and history that helps at least me kind of decide where to go first.
Yeah, it comes down to really assigning of finding a symptom. And if you have a finding, but you can't clearly assign it a symptom, specifically with venous disease that coexists in lymphedema, then you may not treat it. So for example, compression. There's plenty of papers out there that show that compressions are in asymptomatic people. So you have to prove that compression is actually causing something in that patient. You can't just assume that it's there because it's there. It's actually something that is clinically relevant. So it's a very important point.
Yeah. Ron, somebody's asking on the case of a patient with the femoral vein ligation, where the saphenous, we're talking about potentially being a bypass. If you did ablate it, what would happen to that patient?
If you ablate it and it's a bypass, you're probably going to make them worse.
Yeah.
And their swelling is going to get worse because you're obstructing their only outflow from the leg.
In your case, obviously, you reopened the femoral, so you should be okay. But I have seen one of my partner's patients and one from outside facility that had a saphenous vein that was ablated, and actually the edema got extremely worse.
Yeah. Yeah, and I spoke I clearly explained that to this patient. I'm not sure that he could, understand that to the degree that it could happen, but often these patients are desperate. They want their symptoms and their swelling to get improved. And even if you tell them that there's a potential for it getting worse, even with vein closure or treatment, they sometimes struggle to understand it.
Yeah. So, Kush, when you see these patients, do you start off? You're obviously interventionalists, both of you guys. For the audience, that some are therapists. When do you intervene versus continue or start medical therapy, whether it's compression alone or pump or MLD or whatever?
I think as I've personally done, I'm interested to hear what Ron has to say about this. As I've sort of grown in my practice, I've recognized that there is no downside, particularly if there are exam findings that are really consistent with lymphedema, phlebolymphedema, that I just start it right away. Let's do the compression. Let's do the MLD. Let's get the pump process started. You have venous claudication, we're going to treat that as well. And that's primarily what I see in my practice, right? I have CVI-associated lymphedema that's dominant in my practice. Early on, I'd say, I think I was thinking that, the swelling is going to improve and I don't want to get this whole process started. And that's changed. Surely it does improve a little bit, but not enough that anybody is totally satisfied.
Ron, how about you?
I mean, I agree 100% with Kush. I used to wait a lot more. I would try to treat them. I would stent them. I would ablate them. I would watch them. And then they come back and it's 3 months later, 6 months later, and their swelling's not gone away. And I'm going back and saying, hey, we should start doing MLD. We should start getting you a pump. Let's get this process started. And I've shifted to moving it earlier in that. So when I see them, I'm getting them started with lymphedema therapy from the beginning and starting with getting them a pump early on, and then still doing treatment because I think there's still the correlation there. So if there's a venous cause, I think we still have to treat it, but it's nice to get them started early.
So, I mean, definitely I get them started earlier with post-thrombotic and deep pathology. If it's superficial and they have mild edema, I'm not that aggressive. I just start with compression and then treat their superficial. So I just want to make that distinction. I think if they're if they're in the bucket that potentially is reversible with therapy, then you just you fix their venous problem and they reverse. But that's not always the case, as been shown in several studies. How is it possible to dilate a ligated femoral vein?
Strong balloons.
Yeah. And sometimes, I mean, you think you were in the lumen itself, or do you think you created a new track?
I'm honestly not sure.
Yeah.
It was such a scarred down track that we very well could have made a new track. But I did feel like when I did it, at least we crossed through the native channel, or we connected the two native channels very close.
Yeah, that's why I was asking, was it the vein ligated or just divided and tied off? Which, you, again, unless you have the operative report, is impossible to find out.
Right.
But it's not uncommon, right, Kush, where you can actually, even though you're not in the true lumen of a vein, if it's a short segment, you can just go through the tissue, and that's what with the RF or laser, and create a new channel or a new.
It really comes down to thinking about what structures are there and what you have to avoid, right? The artery branches and nerves, and those are the ones you have to avoid. And you know, I've done a recanalization of a ligated IVC, and really the only thing that's there is retroperitoneal fat. So, and it's a straight shot, and you get everything lined up, and you find the oblique on your imaging. That's everything's as close as possible, and then you buzz across that little short segment. And Ron did the same thing here. You know, there's different techniques you can use. You can put a balloon in the artery. I mean, there's all sorts of things you can do, but I think the way he did it is how I do it. But by definition, it's X-ray anatomic. If it's ligated, you're X-ray anatomic.
Did you stent that vein? I couldn't remember.
Yeah, he did.
I did. Yeah.
What did you use?
I think I used a Vinovo at the time.
Right.
So I didn't use a covered stent. I did have a covered stent in the room. I did have arterial access so that if I needed to, I could check to make sure I didn't cause arterial injury. And if I had to fix something from an arterial side, I could. So we took all precautions. Thankfully, didn't need any of them.
And then there was a question about, you know, when do you do a PALMA? I mean, I've never had to. How about you guys? Have you ever had to refer anybody out that you couldn't get through?
I haven't seen Palma stay open, so
Yeah, agree.
Okay. So I think we're pretty good with no residual questions. Thank you, everybody. And I mean, really, as the point of this whole webinar is really think about lymphatics and veins. Whether you're a lymphatic specialist or venous specialist, you really should be thinking about both systems as they really depend on each other and potentially can be causing combined pathology. So I want to thank Tactile for putting this together. Again, another really good event and some upcoming programs that you can see here. If you want to sign up, just visit tactilemedical.com/education, and you can actually get these recorded webinars for access in the future if you want. So thank you, everybody, and have a good night. Thanks, Ron. Thanks, Kush.
bye-bye.
Tony.